Welcome back to Medical Review with Dr. H. Today, we're going to tackle one of the most common and, frankly, one of the most confusing lab panels out there. Liver function tests, or LFTs.
Look, if you've ever stared at a wall of these numbers and just felt completely lost, you are not alone. But I promise, by the end of this, you're going to have a simple, powerful framework to turn that confusing data into a clear clinical diagnosis.
So here's our game plan. We're going to break it all down into 5 key steps. We'll start with how to just organize the data, and we'll finish up by running through some real-world cases to make sure it all sticks.
Okay, first things first, we need a way to organize all this information. I actually draw out my LFTs a little bit differently than you might be used to, and it creates this awesome visual map. So, right at the top, we're going to put total protein and albumin. Think of these as the liver's long-term report card. They tell us about its synthetic function over weeks and months. Then, way down at the bottom, we put AST and ALT. These are our right-now markers. They scream when there's acute damage to the liver cells themselves.
And rounding it out, on the side we have alkaline phosphatase and bilirubin. These guys point us toward the plumbing of the liver, the biliary system.
So now that we've got our tree sketched out, it's time for the secret sauce, reflex testing. This is your if this, then that checklist. When you see one of these numbers go haywire all by itself, what is the very next test you should order without even thinking?
There are 4 of these, and they are absolutely crucial. You need to have these 4 reflexes memorized so you can get on the right track instantly.
First up, the protein gap. You take the total protein, subtract the albumin, and if that number is greater than 4, alarm bells should be going off. It means there are extra proteins floating around, usually immunoglobulins. So your mind should immediately jump to things like chronic infections, HIV, Hep C, or even something like multiple myeloma.
Next, what if you see a high AST, but the ALT is totally normal? Well, you have to remember, AST isn't just in the liver, it's also in muscle. So your reflex is to order a CPK to see if this is actually coming from muscle breakdown, rhabdomyolysis, instead of the liver.
Okay, alkaline phosphatase. This one's tricky because it can come from the liver or bone. So how do you tell the difference? You call in the GGT to be the referee. If the GGT is also high, your alk phos is coming from the biliary tree. But if that GGT is normal, you've got a bone problem.
And this one, folks, is non-negotiable. A high total bilirubin is basically an incomplete sentence. It tells you almost nothing useful on its own. You absolutely must order a direct bilirubin, the D-bili, to figure out if you're dealing with a conjugated or unconjugated problem. Okay, with those reflexes locked in, let's zoom in and look at a few high-yield rules for the analytes themselves.
For low albumin, it's super simple. Just remember the 3 Osis causes. Cirrhosis, the liver factory is broken and can't make it. Nephrosis, the kidneys are leaking it out. And gastrosis, which is just a catch-all for malnutrition or gut issues where you're not absorbing it.
All right, now for a huge diagnostic clue. What happens when you see AST and ALT not just a little high, but skyrocketing into the thousands? Well, your list of possible causes suddenly gets very, very short.
Yeah, seeing numbers this high means a massive acute insult to the liver. Your differential diagnosis shrinks to just these 5 big hitters. Is it a clot, an autoimmune flare, an acute virus? Is the liver ischemic from shock? Or did the patient take too much acetaminophen?
Okay, this is where we really level up. It's time to move from looking at individual numbers to recognizing the broader patterns of injury.
Now pay really close attention here because the infiltrative pattern is the one that everybody misses. So an obstructive pattern is pretty simple. High alk phos, high direct bilirubin, and you see dilated ducts on the ultrasound. But an infiltrative pattern, you get a crazy high alk phos, but the bilirubin is normal and the ultrasound is clean. This means something is literally infiltrating the liver tissue itself. And for jaundice, it really all comes down to that ratio of direct to total bilirubin. If most of it is unconjugated, the problem is happening before the liver. Think prehepatic causes, like hemolysis. If most of it is conjugated, the problem is after the liver, a posthepatic obstruction, like a clogged type.
All right, enough theory. Let's put this whole framework to the test with a few quick cases.
Okay, you see these labs pop up on your screen. AST and ALT are through the roof. Alk phos is normal. What's the very first thing that comes to your mind?
That's it. It's an acute hepatocellular injury. You've just triggered the rule of thousands and boom, you have your short list of life-threatening causes to investigate right now.
Okay, next case. This one's a little trickier. The alk phos is 500,
but the bilirubin is normal and the ultrasound shows zero obstruction. What's your next move?
This is that classic infiltrative pattern we were just talking about. The high alk phos tells you something's wrong, but the biliary tree isn't blocked. Your next step isn't more imaging, it's a biopsy to figure out what's invading that liver tissue.
All right, last one. Look at the ratio here. The total bilirubin is 4.0, but the direct bilirubin is only 0.2. What is that massive amount of unconjugated bilirubin screaming at you?
It's pointing straight to a prehepatic cause, almost certainly hemolysis. The liver's fine, it's just being totally overwhelmed by all the bilirubin from red blood cells breaking down. Time to check a blood smear.
So let's recap the whole thing. It's a simple three-step method. 1. Draw the tree to get your data organized visually. 2. Burn those 4 key reflexes into your brain. And 3. Learn to spot the big patterns: hepatocellular, obstructive, and of course that tricky infiltrative one.
And that's the framework. I really hope this helps you feel way more confident the next time you're faced with a panel of LFTs. If you found this helpful, do me a huge favor and hit that like and subscribe button for more clinical reviews. Thanks for watching.